Hi, folks. Hello. I'm very excited to introduce Dr. Julianna Deardorff. She is a licensed clinical psychologist and associate professor in the School of Public Health at Berkeley, where she heads the Maternal, Child, and Adolescent Health program in the Division of Community Health Sciences. She is the director of the HRSA MCHB, so that was, maybe to remind you, Maternal, Child, and Adolescent Health Funded Center of Excellence in Maternal and Child Health Education, Science, and Practice at UC Berkeley. She completed her clinical internship at Lucile Packard Children's Hospital at Stanford and the Children's Health Council in Palo Alto. Before coming to UC Berkeley, she was an adjunct assistant professor at UCSF in the Department of Epidemiology and Biostatistics. And her research focuses on early adversity, puberty, risk-taking behaviors during adolescence, and related protective factors, particularly among young Latinos. She has a strong history of funding from NIH and currently serves as PI on a large grant examining adversity and sex and substance use behaviors among Mexican American youth living in a predominantly agricultural region of California. She teaches graduate level courses in adolescent health and evaluation of health and social programs. I don't know if you have time to do other things. So it's very exciting. Please join me in giving a warm welcome to Dr. Deardorff.
Thanks for coming. It's really fun to be here for a couple of reasons. One, this is the first time in a long time I haven't talked about puberty, which is my area of expertise, other than the one that you're going to hear about today. And so a lot of these data that I'm presenting today are really hot off the press, and they're the culmination of a lot of work that's been going on down in Salinas, California. That's the agricultural area that we're working in. And I'm really, thank you for inviting me, and I'm pleased to also have Dr. Will Martinez here in the third row. He was a postdoc with us prior to coming here to UCSF. So if anybody has additional questions and wants to tap into what this study is all about, you can chat with Will. All right, so I want to make a note that we're going to be talking about adversity and kind of issues around fear of immigration and deportation, but it's among US-born Mexican-American youth that I've been focusing on. So these are youth who are citizens, but let's back up a little bit and just start. I know that I'm preaching to, I have nothing to disclose. That's, you guys make me do that. I'm going to start by talking about the life course perspective in ACEs, which is going to be so familiar to many of you, so I'm going to try to go through it fairly quickly. But then I want to talk about adverse experiences that are specific to Latinx youth and their families, because those are really understudied and ignored in the literature. I'll give you some background about our study in Salinas, and then talk specifically about immigration policy concerns among our population and fears about deportation, and talk a little bit about how those stressors in particular can get under the skin to lead to longer-term health effects for these families and youth, and the implications as I see them. I'm hoping to leave time for discussion, so I will keep an eye on the time, and even if we have to cut it short, I want to hear if there's any questions from you. So a life course, in terms of a life course approach, like many of you here, I've focused on kind of developmental trajectories, and a lot of the ideas around life course did come out of developmental psychology. And then what happened was folks took a lot of those ideas about how there are critical windows of vulnerability and also cumulative exposure to stress can be negative, and they pulled them together into a framework that really fit well in public health, and that's where the life course approach came from. So it's things that are not unfamiliar to psychologists and psychiatrists in terms of understanding early origins of where health come from. It was Neil Halfon and Michael Liu who first pulled this into the public health and medical domain in 2003. And what they really emphasized was that early life mattered, that differential exposure to risk and protective factors over time shape health disparities, and that they really put an emphasis on structural determinants as opposed to individual behaviors, which is where the focus had been previously, particularly in the medical domain. And the idea was to move beyond just the individual and individual health behaviors to study the broader context and policies that shaped health over the lifetime. Another way to think of, so let me talk about adverse childhood experiences first, and then we'll talk about some other biomedical approaches to life course approach. So all of us, I'm sure, at this point have heard and thought about ACEs, particularly if you're working at the general. But what a lot of people don't know is, even though there's some general knowledge that this research came out of Kaiser and that these studies happened a long time ago, it's actually been 25 years since Felitti and Anda did their original studies in the Kaiser population. And they surveyed over 17,000 adults to understand adverse life experiences that had happened to them when they were 0 to 18 years old. And it was interesting because it was a focus really on a predominantly white population. All of them were insured, and all of them were in kind of middle adulthood at that stage. And yet they found really profound effects in that population. So they asked about things, as you know, like physical abuse, emotional, sexual abuse, neglect, whether you had grown up between 0 and 18 with a parent with a mental health issue or with a substance use issue. They asked about parental incarceration, separation, divorce, domestic violence, suicide, and a multitude of other things. It was quite extensive. And you may know that, but it was surprising at the time, that at least one of these adverse events had been experienced by 2/3 of this population, who was not considered an at-risk population. And that 1 in 8 of these folks experienced at least 4 or more of these events. And these are profound events, salient ones. And they also found a dose-response relationship, whereby the more ACEs that people reported, the poorer their health outcomes were in adulthood. And remember, they were already adults, so we already had these health outcomes documented. This was retrospective reporting. And there was all kinds of outcomes that they found at that time and since, because 25 years ago, there's been extensive research now on ACEs and their effects into adulthood. Everything from cardiovascular risk and heart attacks, and mortality from heart attacks, also lung disease, lung cancer. ACEs have been linked to sexual reproductive health, to mental health, anxiety and depression, suicidality. And I think what surprised people most at that time was also at the very high level of ACEs, it predicted about a 20-year difference in life expectancy. So profound effects. And this is the way CDC has been conceptualizing kind of the ACE pyramid. And I bring this to the forefront because I like that they're not starting with the ACEs at the bottom there. They're actually starting with the generational embodiment of trauma and toxic stress and ACEs and historical trauma. And then at the next level up, thinking about social conditions and local context and neighborhood context. So ACEs is the next level, and that really focused around the family. So if you remember those items I just presented, it's really in the family realm, but I think it's important, especially in public health and public policy, to scope wider and think about what's happening contextually that's driving those factors in the home. And then it talks about kind of mechanistically how we end up in the areas of health risk behavior, disease, and early death. And this is available on the CDC website if you ever want it. So back in the day, and even now, there's really a lot of focus of adoption of the health risk behavior. And particularly when we get into like individual level psychological treatment, mental health treatment, casework, we're really talking about treating the behavior, preventing the behavior. Much of our money in this country goes into programs to preventive intervention programs to try, especially in teens and youth, to try to prevent these health behaviors from happening. But I think we're missing a lot of the bottom half of that triangle when we put all our money there. So I mentioned that there are other ways to look at this same kind of series of effects in terms of the life course. And one prominent model has been the eco-biodevelopmental model that was developed by Tom Boyce, who's here at UCSF, and Jack Shonkoff. And basically, you're looking at a very similar type of illustration of the life course, where on the very far left-hand side, You have these larger environments of relationships, physical, chemical, built environment, nutrition, of course, which are dictated by social policy, both locally, federally. And then they've also added a piece, gene-environment interaction piece, which you could also think about epigenetics, which is a little different. And this top arrow looks at cumulative effects over time, which is really where the ACEs focuses. It's kind of, we tend to take all those things that happen between 0 and 18 when we measure ACEs and count them up and talk about cumulative effects. But I think what's really interesting about this model is that bottom arrow talks about how things can get biologically embedded during sensitive periods of time and maybe pack a bigger wallop. And we're really interested in that because we're not looking at adult outcomes later in life. We're looking at what's happening in childhood and adolescence and how that's shaping trajectories over time. And if we really want to think about intervention, then we have to know what are the critical windows and what are the domains of diversity that are really affecting certain outcomes among youth. Another place our research is focusing, as you'll see, is on how does the body physiologically adapt when it's exposed to chronic stress or stress during these developmental windows. What are the biophysiological embodiments of stress? And then finally, the lifelong outcomes that we were talking about, the health behaviors and also the disease outcomes and mental health outcomes. So many of you know who Nadine Burke-Harris is. I know she's spoken here many times and she's come up, we've been lucky enough to have her come over to Berkeley. She's the first appointed California Surgeon General, which is nice given her focus on ACEs. She took ACEs and brought it back into childhood. So she was working in the Bayview as a clinician and running a clinic for CPMC, and she noticed that there was just far too prevalent, there was far too much asthma, respiratory disease, ADHD, you name it, among the kids that she was seeing for it to be accounted for by normal individual trajectories or health behaviors or family behaviors. And she really started thinking more broadly about ACEs in terms of not just in the family, but in the settings that kids were living in, and in terms of the policies, which is why she's now in the state capitol. And she started thinking, we need to turn these ships before adult disease becomes intractable, and brought it back to childhood. So again, none of the ideas were new, but she brought a whole new resurgence and energy into this area of study and brought it back into childhood and adolescence as important developmental windows.
She's talking tomorrow at 11 here, by the way. It's a free event.
But who's been left out of this conversation? In large part, the research has focused on African American and white individuals, and it has not focused on Latino families to the same level. And to her credit, Dr. Burke-Harris has actually been talking quite a bit lately about the threats of deportation, family separation, and the toxic stress associated with just the general culture of what that feels like around families, even if they are US born. And the lack of safety and the discriminative rhetoric that's happening at the federal level and trickling down. So that's what we're going to turn our attention to a little more here today. What kinds of stressors affect Latinx families in general? Well, if you've studied this area of psychology, they talk a lot about acculturation stress, moving from another place, learning another language, leaving your family, trying to adapt to new cultural norms, but also retain your cultural values, exposure to discrimination, and that's discrimination with a big D, and also microaggressions that happen daily. We know that those get under the skin as well. And also just the challenges of navigating institutions that are unfamiliar to you, particularly if you have limited language, or education, so medical, school, social services. And like I said, things have changed recently in this country in the last 4 years. So even prior to the presidential election, the level of harsh rhetoric around Latino immigrants, and also the rhetoric around how immigration policies were going to change started far earlier than the actual election. And we've noticed it in our community, and I'll talk a little bit more about that in terms of people's worry and fear. How does it affect U.S. Mexican origin youth? So these are our U.S. citizens, right? They shouldn't be struggling with this thing. It's not true, and people are not paying close attention to how we're not doing a good job of protecting our U.S.-born youth. So for starters, before all this rhetoric got more intense, they were still struggling with normal adolescent issues, navigating high school and peers and all the things that adolescents have to deal with, and discrimination and the things I mentioned before, but also navigating generational gaps with parents, which, not just US born youth, but immigrant youth acculturate much faster than their parents, and they adopt the cultural values of the host country much more rapidly. And so those conversations in the family can result in a lot of conflict, particularly around adolescence, when the values really change, and youth are still finding their identity, and they may not have enculturated quite as much, so held on to their cultural values at that moment in time. They may pick them up back later, but it's a really tough time for youth and families. They also may have served and are serving in language brokering roles for their families for years that are way over their pay grade, trying to fill out forms, trying to talk to people on the phone, trying to navigate their family's medical care, going to the bank when their parents are scared to leave the house because immigration is hanging out near the bank. I mean, these are things that happen in Salinas and here. So to add upon that, a heightened level of deportation fears beyond what was already present can have a profound effect. So let me just talk to you a little about Salinas. You may know about it. It's only about 2 hours, a little over 2 hours south of here. It's in Monterey County, which is one of the wealthiest counties in California. So you think about the coast of Monterey and how pristine and beautiful it is, and then Salinas is also beautiful. It's an agricultural area that's inland, but it, as Will and I used to talk about, I think you used to start your talks, Will, saying it's a small city with big city problems, and I think that's accurate. So in Salinas, not Monterey County, 75% of the population is Latino, mostly Mexican. 31% live below the poverty level. Half of the students are on subsidized lunch, and a third don't graduate from high school. Only slightly better than the 50% when I was working in Arizona. There's a very high teen pregnancy rate, and if you ask the medical providers in that area, that's one of the things they identify as their biggest issues. And the homicide rate is extremely high. It's twice that of Los Angeles. And Salinas has actually been identified as one of 6 high-risk communities in the nation for youth gang violence in the United States. So that's the second thing that providers will tell you. We're worried about gang violence in this community. It's also, as I said, an amazing place with a very rich history. It's called the salad bowl of the nation. It produces 80% of the lettuces and salads in the country. It's the birthplace of John Steinbeck. It's just miles from the prosperous Monterey coast, and it has a rich history of farm worker advocacy. So there's a lot of power in this city as well. So let me tell you about our study. We started this study, I say we loosely because I didn't join until about halfway through, but 20 years ago, my colleague Brenda Eskenazi, who's an environmental epidemiologist at UC Berkeley, started this study because she was interested in the prenatal effects of chemical exposures, pesticides in particular, on fetuses. And she wanted to catch moms early, so she went to prenatal clinics serving the Salinas area and recruited pregnant mothers because she was interested in the neurodevelopment of their offspring, of their babies. So she recruited 600 pregnant women in about 20 years ago, 1999 to 2000. Predominantly spoke Spanish, 85% were born in Mexico, so largely an immigrant sample. At the time of birth, half of the sample had lived in the United States for less than 5 years. Pretty much ubiquitously, people were living in poverty. 44% had a 6th grade education or less and worked in agriculture. These are the pregnant mothers. And 84% had farm workers living in the home, their partner or other folks. We've been in Salinas for a long time. We've followed these youth at multiple time points. This kind of maps out our timeline. There were 2 visits in pregnancy. We saw them at multiple time points in their early years because Brenda was tracking neurodevelopment. Saw them through childhood, and most recently we've seen them at 14, 16, and 18 years of age. which is where my study focuses on. We're actually still in the middle of our 18-year visit, but it's really interesting because the youth are transitioning now into emerging adulthood, and they're starting to leave high school, and we have a good sense of who they are and somewhat of where they're headed. We have done so many different types of assessments, and we're so grateful to these families. I'm not going to go deeply into it, but Chamacos was a community-based participatory study, and it was done in combination with the community. We didn't just go in and start asking people for all their data and then leave. Brenda sat down at the table with representatives from the farm workers, the schools, the clinics, the hospitals, and actually the growers, because they're a really important political part of the setting down in Salinas. And really everyone came together around, this is about the children. We're trying to help kids. And we have, throughout that time span that I showed you, have done educational events, backpack giveaways. We're not trying to keep strategies from people about how to protect themselves from pesticides. We were actually helping them learn how to protect themselves and how to provide more neurodevelopmentally positive household settings, gave away books, those kinds of things. We also, it turns out, we had real fears during this administration that we would lose our sample, that people would be scared to come to us. And lo and behold, it turned out that they felt safe coming to us, but not going to other places. So they came to us to ask us for referrals to legal care and a variety of other things. And at that time, we actually we pushed out information about what do you do if immigration comes to your door, and did informational sessions around that. As the acting psychologist on this study for the last 10 years, I have fielded everything from reports of incest, suicidality, you name it. So we're definitely embedded in the community, and everybody working down in Salinas is from Salinas. It's not us. And in fact, one of our nurses, and I don't know if she's in this picture, one of our women was there when the babies were born. So, and she still works for us. She's our number one recruitment strategy. So we did all kinds of things. We tested the children. We determined when they entered puberty by physical exam, measured their height and weight. And more recently, we have a lot of measures of self-report of how they're doing. I just have to mention that we have also gotten hundreds of thousands of biospecimens that are banked at UC Berkeley. Really important when you're studying chemicals, right? You want to know if they're in the breast milk. You want to know if they're in the urine. And there's a host of other studies that focus around those types of things, which I won't go into today. But a very rich data set. There you go, 350,000 samples that we need to maintain funding to store at UC Berkeley. We did home assessments early on, so people actually went out to the home and looked at the quality of the home environment. We did the home scale. You use those data a little bit. Parenting behavior, both vis-a-vis observation and asking questionnaires. Observable things like rodents, the availability of blocks and toys in the environment, all that kind of stuff. So early adversity, not surprisingly, these youth were exposed to quite a bit of adversity from 0 to 5 years old. And we have measures all the way through. I'm just focusing on early childhood for now. 40% of the youth had at least one stressful event. This was measured not vis-a-vis the ACEs, but vis-a-vis the Coddington Life Event Scale, because we actually wanted to know when these things were happening, at what ages, and at what frequency. I just write this because it's just shocking. 60% had a mother who was depressed on the CESD, at least at one time point over the 5 years. And in fact, actually, I think this is not just at least at one time point. I think we were looking at more than one time point to rule out postpartum effects, postpartum depression. 64% spoke only Spanish in the home. That's not an adversity, but it can become one if you have a child who has a language broker for you. It's actually great to speak Spanish in the home, and I'll show you later that bicultural kids do better. That's a good thing. 13% had a parent who died, and 8% had a parent who was jailed. And I have to say, one of the things that keeps coming back to us is moms or dads with very rare types of cancer coming in asking us, is this related to the pesticides that we were exposed to? And honestly, we don't know. but the prevalence and the frequency seem too high to be coincidence. Adolescents have adversity. We mentioned that. They go to high school, and high school's hard, and school is hard, and peer relations are hard. On top of it, these youth are experiencing different kinds of peer hassles. They have economic concerns. As I mentioned, we've assessed parent, adolescent, and family conflict. We also have cultural values and norms from both the parent and the child to see if that's actually part of what's happening in the household. These kids are experiencing food scarcity, although I have to tell you, they don't report high food scarcity because their moms in particular, their families are really protecting them from going without eating. It's the moms who are experiencing the food scarcity to make sure their kids can eat. And a host of negative life events that we've also measured in adolescence, like discrimination and various other things. And then when our kids were 16 or turning 16, as I mentioned, a new administration was ushered in. And so sadly, we had this natural experiment to test how this affected the youth in our sample. As I mentioned, there was more negative rhetoric. Salinas was not immune from that, even though it's a city and a sanctuary state. People are still scared. ICE raids were increasing in the area. Kids who are under DACA were being challenged, so some of these youth's friends or siblings or cousins, and family separation was publicized in the media and lauded by the administration. So what we did is we took a subgroup of youth from our sample of 600, so 397 kids, and we chose, for this study, we included the youth who had at least one immigrant parents. So we did know where people were born. We didn't know their citizenship, but we knew where they had been born. In fact, we didn't ask about their citizenship purposefully because we don't want that information. Parents and youth were interviewed in clinic at 14 years old, which was before the presidential campaign. It was just part of our natural visits. And then at 16, these youth were in about the first year of the election. So we were really interested in what was going on based on what was happening in the country. And we asked them questions about their perceptions of immigration policy. Questions like, in the past 3 months, did you fear that you or your family would be reported to immigration? Do you worry about family separation and deportation? And a whole host of other questions. We also did the behavioral assessment system for children where we asked them about their anxiety and depression, and we were interested in sleep quality. And so not just sleep quantity, but were they having trouble with their sleep? And here's what we found. We found that 21% of the youth were really in the high category of immigration and deportation kind of worry concerns about policy. And the reason I isolated that wasn't to show you that 80% were fine. They weren't fine. Many of them had moderate concerns, but we wanted to isolate the high group to see what was going on with them in particular. And in reality, almost half of the sample reported concern about immigration policy in terms of their family, or were worried about separation due to deportation. About 40% were worried about family members being reported to deportation officials. And this is not in this scale per se, but I wanted to show you that even at that one time point, just at 16 years, almost 40% of the mothers were clinically depressed as per the cutoff by the CESD. We didn't actually assess clinical depression, which is really high. So immigration concerns, that high group that I was showing you had significantly poor sleep, dramatically poor sleep, and they had much higher anxiety that was in the clinical range as per the cutoff on the VASC. And these data were published in JAMA Pediatrics, if you want to go back to the original paper, recently last year. In addition, over that 2-year period that I was talking about from age 14 to age 16, when the administration was changing over and the rhetoric was changing, their anxiety elevated among this group that had high worry about deportation and was concerned about immigration policy. It went even higher just in those 2 years. So anxiety, depression, sleep, and there was a trend for depression as well, not surprisingly, even when you controlled for mom's depression. So here we are at the disease end of the platform, and we've talked some about adverse childhood experiences, getting more into social conditions, and also this kind of generational embodiment of trauma that's going on given the social constructs and the trauma that parents bring over with them. They left for reasons, right? So things to consider. But now I want to talk just a little bit about disrupted neurodevelopment. And this gets back to the question I raised earlier about how stress gets under the skin and how we tested it in our sample. So we know that adversities experienced early in life can enter the skin to impact stress responses during adolescence. We also think that there's probably a critical window in adolescence when adversity gets under the skin as well. And we've just submitted a grant to try to look at that as well. So cross your fingers. We did the TIERS social stress test. Do people know what it is? I want to get a sense of how many people know what that is. Okay, not too many, so I may show you a video. This is so foreign to me because I'm a clinical psychologist who intervenes to reduce stress in kids, but I work with a biophysiological psychologist who's really into trying to figure out in a laboratory how to get stress up so you can see how kids adapt to stress and can solve it. So we found that the best way in adults and in adolescents to create stress is to make people give a speech. And people don't like giving speeches. It's also relatively innocuous. You recover from it, and it doesn't create lasting trauma. So we had them give a speech about why you're a good friend, and we had them do some mental math, which nobody likes, counting backwards by hard numbers to subtract. And then we assessed their hormone reactivity, both in terms of salivary cortisol, and we actually looked at sex hormones too. Testosterone moves in response to stress, but I'm not going to present those data today. That was interesting. And we looked at other kinds of reactivity measures like heart rate, RSA, and PEP. And do you want to see just a little video about what this looks like? This video doesn't do a great job of it, but I also want to say we culturally adapted the TSST to work with our population, because when we started doing it, our youth were breaking down. It was too much. With the level of trauma that they experience, the idea of being put on stage and asked to do these things was really rough, and some of them were academically challenged, and it was just, so we made the math easier, we shortened the whole thing. We had kids telling us they were going to come back and shoot up the place. We were highly motivated to shut the study down, and we did. We shut it down for a couple months, adapted it till we got to a point where kids got stressed, but they didn't get overloaded. And it doesn't work for us if they get overloaded, because then the cortisol, everything's a mess. So this is just to say this was probably the hardest part of this entire study to do for me, being a clinical psychologist, and it's the part that gets us the attention. I just spoke in Sacramento on Monday, trying to advocate for better policies for US-born youth of immigrant parents. And what do they want to know about? They want to know about the neurons, they want to know about the brain, they want to know how the stress gets under the skin, so they can go out and advocate. So here I go. I'm going to see if I can make this work, and if not, I have a friend over here who's in the wings who's going to help me. Okay, it's up here, but how do I don't know how to click on it on here. So I think I do need to maybe escape. Oh, you said I could just play. No. I forgot to play, sorry.
The overall procedures is psychological stress.
This is actually part of the stress experiment. I'm stressing you out.
This method can help you.
Is here. Oh, look, there's Megan. So Megan is a postdoc that worked with Will in my lab, and she is all-knowing in terms of hormones, collecting saliva, storing spit, sending it far distances. I want to point out this journal. It's a really interesting journal. It's called the JOVE, or the Journal of Visualized Experiments. It's actually quite expensive to publish in, because what they do is come out, did you do this before? They come out and video you. And they do it for kind of prototypes, to send out models of how you do these complicated tasks, different kinds of tasks, and make it available, open access to globally. So if somebody we've had over 4,000 hits, I think, to this website and numerous emails from people in different parts of the world trying to figure out how do you do this task with vulnerable youth in different settings. So it's been a great way to get the word out. But basically what this video does is shows Megan walking, these are our undergrads, walking them through the TSST. And so the speech is given in front of 2 Confederates, and we take saliva basically at 5 different time points in order to get cortisol, to see a cortisol curve. And the goal is to get the cortisol up because it's a normal response to stress for cortisol to go up so that you can respond. But your hope is that people will emotionally regulate and that their cortisol will go down before they leave our clinic. And so you're looking for a nice curve. And after we do it, we talk to them, we explain it to them, we actually show them their heart rate and various things. They're interested, they forgive us, and they do recover biologically, which is probably the most important thing as well. Okay, so sorry I can't show you that, but you can look that up. And what we found is that these early life events that we were talking about do show a cortisol response at age 14, and that when the effects are negative, they show a more maladaptive response to the stressor that I showed you. So things like low SES, parent divorce, and having a family member deported showed more maladaptive cortisol responses in our youth, whereas enriched home environments, maternal responsiveness, showed more adaptive stress responses. And I want to point out this right side of the slide because it's really important to know what's protective as well. Okay, and this is, these are kind of the results that I was speaking to before about how the bicultural youth seem to be doing better when we looked at their cortisol patterns in response to this stressor. So for this study, we looked at 264 youth who completed the TSST. We gave them a brief version of the ARSMA, that's not spelled, it's not ARMSA, it's ARSMA, to see whether they were endorsing kind of Anglo orientation, Mexican orientation, or both orientations. And then at 14, 2 years later, we did the TSST, as I mentioned. And what you're seeing right here is that the youth with both cultural orientations have the kind of curve we like to see. They are responsive to the stressor in the lab and they recover really nicely, whereas we're getting kind of a flatter effect, a more blunted cortisol effect is what we call it, which is actually illustrative of trauma. So another thing to be thinking of, this has implications actually for intervention, because right now a lot of, in our school system in particular from very young ages, youth who don't speak English are being shuttered into ESL classes. They're getting tracked, and there's not a whole lot of integration. It's like stratification from very early ages. Those kids don't have access to honors classes later sometimes if they get tracked, and it ends up being a catch-all for kids who are thought to be not good learners. So really I think that there's a lot of evidence that we need to have more integrated classrooms and that kids need to retain Spanish as well in English, and that bilingual immersion is probably the way to go. What about moms? I don't want to leave moms out because they've been such great participants in our data. They're clearly affected. These are some of our community forums, the one on the left. Unfortunately, a lot of our moms in our sample are worried about deportation for themselves or others. Again, we never ask the question directly about the mom because we're not trying to find out about citizenship status, and we don't want that in our data or records. So at 12, we asked them how they, so this is a little earlier, so this is where our 16-year visit that I showed you before. We asked them about worry about deportation. And we found, not surprisingly, if you look at the middle bars, that the immigrant moms, the ones who had immigrated to the United States, had a lot of worry or moderate worry. So over 50% had a lot of worry about deportation about family members or themselves, and 25% more had moderate worry. So very few weren't worried about it at all. And if you look at this, I'll just summarize this for you, but basically a lot of worry is the blue line and moderate worry is the green line. And this shows the effect on mom's systolic blood pressure. We also found, as you see over here, that worry about deportation was also related to higher obesity. So that combination of obesity and higher blood pressure taken together really puts these moms at risk for increased cardiovascular problems. And they're probably in their early 40s, late 30s at this time. So we're not talking older, not people like my age, talking younger people. Moms are overweight, and so are youth. This isn't surprising. We know there's lots of structural reasons for this. And there is hypertension in this population. It's even higher than this because some women were on medication, so they were excluded. But look at the sons, 27% have pre-hypertensive symptoms, and this is at 16 years old, right? Good news. It's been too much bad news. Good news, there are protective effects. We found that even though these families are predominantly living in poverty, particularly early in life at age 1, we found that did have negative effects on their stress reactivity at age 5. Maternal responsivity was a key factor in buffering. And in fact, I'm going to show you a slide that looks complicated, but it's really not. What we found is the blue line is the highly responsive moms. And among the highly responsive moms, even in the poverty category, which is that high left category that you see that, so high responsive, low income, it's that quadrant that's on the far top left, they had really good stress profiles. That's what that predicted RSA is. They were actually doing better than the ones in high SES with the lower maternal responsivity. So moms are important. And that's why I gave you the moms data, because we have to keep our moms healthy and safe in order to provide those kind of nutrients in the home for their youth to feel safe, right? I'm not going to talk about this, but we did not make the kids give speeches. We put lemon on their tongue and we showed them video clips. That's how we did that when they were little. And finally, what we're looking at now is what are the positive family and cultural factors that buffer some of these really adverse life circumstances early in life on the risk-taking behaviors we're seeing in youth. So my work, Will's work, focuses on substance use. We're also looking at sexual behaviors. And my colleagues are looking at delinquency. Unfortunately, we're already dealing with incarceration with some of our youth, and touch points with the police, which can be discriminatory touch points, those kinds of things. And we're showing some signals for maintaining your cultural values from your country of origin, maintaining strong ties with your family as being really protective. And those give us some places for intervention, despite how negative the rhetoric is in terms of immigration and immigrants in this population and in our country. So, as clinicians, we intervene individually. That's what we know how to do. We teach kids and their parents better coping strategies, which we should do. We should help them maintain responsivity and warm relationships in their home. We teach them emotion regulation skills, mindfulness strategies. These are all good things, but they really are not enough. They're not enough because most of these families don't get the help they need. They don't get to us, especially in Salinas, where mental health care is abysmal and waiting lists are miles long. And even if they did get that help, I guess I want to argue as a public health person and somebody who's really thinking about policy, would it be enough? Is this really where we should be putting our efforts and our money? It's what we have to do now, but I think policy is just critical. And I think as mental health workers, as psychologists and psychiatrists and caseworkers and people on the front lines, we have to start using our voice. And that's why I stepped out of my comfort zone and went to the Capitol on Monday. That's not my place, that's not my space, but I did it. Because they're contending with these unsafe environments, chronic fear, chronic worry. It's coming from the federal level. Yes, we're a sanctuary state, but we could do more to protect people and keep them safe. It's especially challenging when the adversity involves policies that threaten family separation, which, to be perfectly honest, is one of the biggest adverse life stressors that cause long-term risk to be separated. There's studies from Romania. There's studies of various kinds of institutionalization of children from World War II, and we know that really gets under the skin. And so what are we doing separating families? We've known this for decades to be bad. And there's this chronic exposure to threat. Living in kind of a threatening environment really gets under the skin cumulatively. We know that over time. So families can't be strong unless they have policies to remain healthy. And I have to tell you, the good news is our kids are doing really well on the whole. The youth in Salinas are doing, in our study, are doing quite well. And we're gonna figure out what it is about those resilient families that's working and see if we can get it out more, but we really need to get things up to the policy level. And that's things like strengthening our sanctuary policies, expanding, not limiting Medi-Cal coverage, making sure everyone continues to get access to high quality education, maintaining our fair housing ordinances. There's protection in courts where they're not allowed to ask you about your immigration status. We have to fight for these things so they don't disappear, and there's more that can be done. So I just want to thank Brenda Eskenazi, our team. We have a huge team, multidisciplinary. Our funders, mostly NIH, and in the past, the US EPA, not so much anymore. And a special thank you to the families. This is a girl at about 12 and her baby shirt when she was born into chamacos with her mom. And I'm happy to field questions. And I stopped 10 minutes early, so yay. Thank you. Hi, yeah. Yeah. I have so many papers. Yeah. Right. Yeah, that's a good question. Oh, I'm sorry. Oh, of course, there's people listening out there. All right. So let me make sure I got it right. You were asking in the study about immigration policy concerns, we had isolated that 24% of youth who really had high concerns about family member, friends. We know they're US citizens, but immigration policy and how it might affect people around them. And you asked what was characteristic of those youth and what they look like. And then you also asked during the, at least for us, it was a 2-year period where we were tracking them from 14 to 16. Now we have age 18, which we haven't explored, how since the administration has come into being, this current federal administration, have things maybe changed, right? So the first question is, we isolated that 24% because they really looked different in terms of, not just in terms of their worry about these immigration policies, but also in terms of kind of the things that we were looking at in the sample, like their anxiety, their depression levels, and their sleep quality. And there was just kind of a natural separation in the data where they were doing much worse than those who were reporting low or moderate worry. We haven't looked at a lot of other outcomes. We did look at blood pressure and didn't see, because we've been concerned about those boys that I showed you that had those kind of higher prevalence of hypertension, and we didn't see a signal there, but we're gonna keep following them. Some things don't manifest until youth get older, and so it's going to be interesting to see how things come out over time, to your point. So we had not asked the youth about their immigration policy concerns until they turned to age 16. So that was one thing we didn't have the capability to track over time, but we have asked them again at 18. And we did see, regardless, as I mentioned, among those youth that were really worried about immigration policy at 16, we had seen worse trends for them in terms of their anxiety from 14 to 16, because we had those data in hand. How that's going to look at 18 remains to be seen, but my guess is as we move into emerging adulthood, and particularly if we're funded at 20 and 22, which is what we hope will happen, that we'll see things, it's sad to say, but things pop in early adulthood. I don't know who here works with like 20 to 24-year-olds, but that's where we start seeing in the general population more substance use disorder, binge drinking, STIs, those kinds of things. And we'll be able to look at how much the culture of fear kind of drove some of those effects for these youth. None of that work has been done before. Very little in Latino populations, very little over time, and almost none in a longitudinal cohort like that. So it remains to be seen. But one of the foci of the grant that we just submitted is really on what's protective. And not just early in life, because so many other things happen as life marches along, but what's protective more proximally in adolescence, because we now know that adolescence is a huge time of growth and brain development, and that's partially why we're focusing on it in terms of the biophysiological responses, the stress responses, and I think there's huge opportunities there to turn the tide, particularly when you have youth in Salinas who are actually pretty civic-minded, in some of them, and how we can engage youth to really feel more in control of their context and their destinies. And we have engaged some youth. We've done some youth participatory research. It's been great. So stay tuned. Yeah.
Does your work speak to prevention of teen pregnancies? I mean, it's a big statistic for the population of this movement. So, and whether you have any recommendations for how to address that clinically.
That's a great question. So the grant addresses a lot of issues around sexual risk-taking, access to contraceptives, willingness to use contraceptives, availability, stigma, those kinds of things. Couple characteristics, a little bit less so, but we tried to get it, especially violence and gang violence, and what it means to be a couple in those contexts. We haven't had a chance to look at it yet. So it is all there. I have another colleague, Ali Minnis, who is at RTI and has another study in Salinas. And cumulatively, we can look at our sample of 600 and her sample of 600. We have 1,200 youth. And she has a very strong focus on sexual reproductive outcomes. And we engineered those questions to be similar, to be able to look at this very large sample of youth over time and try to figure out what might be those pivot points. But I can tell you right now, I went to the Planned Parenthood in Salinas. It's beautiful, and there was nobody in it. And so there's something about getting there, the stigma attached to getting contraception. We have, we study sexual values like around Maria Mismo, and female virginity is important, and how much youth are endorsing those kinds of narratives. I wish we had qualitative data. Ali does, so we'll have more information downstream for that. Yeah. That is a great question. We don't work in the high schools. Ali Minnis would know whether they're embedded in the high schools. I'm not sure, but I can give you her contact info, and she could let you know that. Yeah.
The structure of there are all these different measures taken. Where is your there? Are you traveling around in the schools?
It's a good question.
Primary care, how are you doing it all?
That's a great question. So Ali's study is actually being done. She recruited through the schools, and she's working closely with the schools, and she uses satellite clinics near the schools and sometimes in the schools to do her work. Because we started so long ago with our moms, we're in a office trailer on Natividad, which is the hospital, and right across from the jail. It's this compound-like area. And we have never moved because the moms can find us, they know how to get to us. We provide taxi vouchers for them to get to us to make it really easy. Folks come into town if they're from far away and they get all their stuff done, and then they can taxi back. And when they really can't get to us, we come into their homes and do home visits as well. People have moved, so we send teams of people all the way south in California and to to local states. We don't go back to Mexico, but we go to local states. And most people come back. Part of the reason we picked Salinas as the place to do this work way back when is because even though folks will leave to do farm work in other areas part-time, it has a pretty stable population of farm workers. So the intention was to be able to follow them over time. But yeah, we've discussed at various time points if we should move off of Benetividad campus for various reasons, and you really have to stay where you are. People know where they're coming to and they feel comfortable coming there. In our next iteration with youth, we've proposed to do it all online though, for the youth, not for the moms, because they will start to move out and go to different places and be harder to capture and bring in person. Yeah. The moms are really aligned with the study. You know, we try with the youth, but hey, you know, they're 16, they're 18. Their moms are the one that, come on, we're going in. This is what we're doing. Yeah. Anybody else? Okay, well, thank you so much for your time. I appreciate it.